Let's now move into the physical examination and talk about some of the inconsistencies that we may find in the physical examination. Now, still talked about in the literature regarding malingering are the now classic WADDELL'S signs. These were described by Gordon Waddell, MD, in his 1980 article, Non-Organic Physical Signs in Lower Back Pain. That was found in Spine Journal. Now, recently, since 1980 up to present, the WADDELL'S signs have come under scrutiny, and it's now generally believed that the WADDELL'S signs are not able to reliably discriminate organic causes of back pain from non-organic causes of back pain. And by non-organic, we're referring to pain that's reported to be present, but in the absence of a structural or physiologic cause for the pain. Non-organic pain is pain in the absence of a structural or physiologic cause for the pain. And it's now found that the WADDELL'S signs are not able to discriminate between organic and non-organic causes of pain. However, the presence of WADDELL'S signs on physical exam are relevant in the prediction of poor treatment outcomes. And this is important because by the time most examinees get to the qualified medical evaluation, that is, at least in cases that are not Labor Code 4060 cases, denials over or disputes over liability, those are cases that we might see within 90 days after the date of injury, and the examinee may still be in the acute phase. Most times, however, when we see examinees for qualified medical exams, they're in the chronic phase, and by the time the examinee finally gets to the QME, poor treatment outcomes have often been established, and WADDELL'S signs have been proven reliable to be strong predictors for poor treatment outcomes. So, in my opinion, the WADDELL'S signs are still valuable and they're still illustrative. And taken together with other findings on physical exam and on interview and on medical record review, the WADDELL'S signs can give an evaluator an indication of the examinee's true condition and true level of permanent impairment. And you may see references in the medical records, and I know I see these frequently, on the physical exam section of medical records that you get that, for example, the examinee may have 2 positive WADDELL'S signs or 3 positive WADDELL'S signs. This indicates that the examiner who did the examination, the treating doctor generally, he actually considered the possibility of symptom magnification or malingering, and he attempted to test for that possibility. So let me state that again. If you see in the medical records indications of positive WADDELL'S signs, and you might see it say 2+ positive WADDELL'S signs, 3+ positive for the WADDELL'S signs, 4+ positive WADDELL'S signs, etc. You get the point. If you see that, that indicates that the examiner, which is generally the primary treating physician, he actually considered the possibility that symptom magnification or malingering was present, and based upon that possibility, he attempted to test for the possibility. He consciously went ahead and did the WADDELL'S maneuvers, and he found some inconsistencies, and he's reporting that to you. So in such a case, and because of the seriousness of such a finding, you'll want to repeat that assessment to determine if your findings are similar to the findings of the prior evaluator. Now, Gordon Waddell, he described 8 physical examination findings. Those are known as the WADDELL'S signs, in 5 different categories of testing. Number 1 is the palpatory exam. Number 2 are the simulation maneuvers. Number 3 are the distractive maneuvers. Number 4 are non-anatomic or regional findings. And number 5 are overreactions. And we'll go over these one at a time in detail here. Those of you that have the PowerPoint, and even those of you that don't, I guess I've included in your reference materials a matrix, a Waddell's signs matrix that breaks out the 5 categories of testing and the 8 Waddell's signs, breaking those signs out by category. So this will be a useful memory stimulator and a reference tool that you can use to be able to remember and apply the Waddell's signs quickly and efficiently in your examination procedures. Now, Waddell described 8 signs in 5 categories, and Waddell described a psychologic contribution. He stated that there was, quote, a psychologic contribution to the reported symptom picture with a finding of 3 or more of the Waddell signs. So let's go over now the 5 categories of testing, and we'll highlight the 8 Waddell signs. First is the tenderness assessment. With tenderness, there's a finding of report of tenderness to light touch of the superficial skin. That's the so-called superficial tenderness. An example of a finding of tenderness would be an examinee with a reported disc herniation at L5S1 who reports tenderness to light palpation or light probing of the lumbar paraspinal muscles. Now, because of the paucity of innervation of the superficial skin, there should not be superficial tenderness to light or even moderate palpation of just the superficial skin and subcutaneous tissue. However, as with all findings, the report of the examinee must be put into the context of the amount of force applied by the examiner. A true finding of significant tenderness would be accompanied by a jump sign or a flinch sign. A report of superficial tenderness without a jump sign would be a suspicious finding, or at the most you can conclude that tenderness, the report of tenderness, would be minimal tenderness only, because there's no handicap in your ability to perform the palpation. The tenderness does not handicap your palpation. That would be a finding of minimal tenderness at most. Another example of suspicious tenderness would be a report of diffuse or non-localized tenderness in a non-anatomic distribution, such as the case of an examinee who reports, for example, lateral thigh and knee pain to light palpation of the lumbar spine. Pain poorly localized in a non-anatomic, non-dermatomal distribution could indicate positive Waddell's findings. One would be a positive finding for superficial tenderness. One would be a positive finding for non-anatomic tenderness. Waddell described various simulation maneuvers, and these were strictly in relation to lower back pain. Later on in this program, we go into some maneuvers related to other types of conditions, but Waddell was concerned with lower back pain, And simulation tests are tests that would appear to be testing for a true medical finding, but because they don't actually produce the movement or the stress that they appear to, a positive finding on these tests would suggest symptom magnification. For example, in the case of a lower back injury, an examinee may report pain with twisting and or pain with lifting, and that's common. People will tell you that they have their back pain is exacerbated by twisting, or that they've lost ability to lift, or that they have pain with lifting. And Waddell, he described the axial loading and the trunk rotation maneuvers to try to distinguish true physical findings from symptom magnification and or possible malingering. I'll describe these maneuvers here now. With axial loading, with the axial loading maneuver, the examiner stands behind the examinee. The examiner places his hands on the top of the examinee's skull and applies pressure down the axis of the spine. And just a note, doctors, when performing this maneuver, make sure to apply pressure gradually and do not injure the cervical spine. As an alternative, some examiners ask the examinee to place his own hands on his skull and to himself apply the downward pressure. I like to do this maneuver myself, and I'm very careful with it. And I like to do it myself because I can gauge the amount of pressure that's being applied. Now, a positive finding on this maneuver would be an examinee that reports lower back pain with applied pressure down the axis of the skull and cervical spine. And this is considered a non-physiologic finding. This is considered a positive Waddell sign because this maneuver does not actually apply significant pressure to the lumbar spine and therefore should not aggravate back pain. With truncal rotation maneuver, the examiner sits on an examining stool or kneels on the ground. I do this on an examining stool. And you can sit either to the front or the back of the examinee. I like to sit in the front of the examinee so that I can observe their facial expression. And the examiner grasps the examinee's hands, and the hands are going to be hanging to their sides in their normal posture, and grabs the hands around the wrist and applies downward pressure down the axis of the arms. Simultaneously, the examiner rotates the shoulders and torso by directing the motion at the examinee's arms. So can you picture this in your minds, doctors? You're sitting to the front of the examinee, their arms are hanging down to their side, and you simply grab their wrists by encircling the wrists with your thumb and index finger, and you apply pressure down the arms by pulling down on the arms. Then, using the arms as your levers, you rotate the examinee left and you rotate the examinee right. Now, this maneuver appears or simulates, and that's why it's called a simulation maneuver. It simulates a twisting motion, but in actuality it produces rotation only at the hip sockets by moving the torso and the pelvis together en bloc. En bloc means all together. So the pelvis and the torso move all together, and there is actual no motion at the lumbar spine. But examinees, they don't know this. That's why it's called a simulation maneuver. A report of lower back pain would be a suspicious finding for symptom magnification or malingering. Waddell also described several different types of distraction maneuvers, probably the most famous of which is the sitting versus lying straight leg raising maneuver. Now, these are tests that are based on reported positive physical examination findings, such as reported lower back and radiating left leg pain on straight leg raising. So you have an examinee that reports lower back and radiating left leg pain on the straight leg raising maneuver. And then this finding is followed up later on in the examination while the examinee may be distracted. That's why they're called distraction tests. So in this case, the examinee may be seated, and you'll do a seated straight leg raise maneuver under the guise of checking Babinski reflexes, for example, or under the guise of doing a sensory testing on the foot, or under the guise of eliciting the patellar reflexes. In any event, the examinee is sitting, and you simulate the straight leg raising maneuver while they may be distracted. Now, because the overt physical examination maneuver in this case is the straight leg raise test, and the distracted physical examination maneuver in this case is the sitting straight leg raise test, since these two maneuvers produce the same anatomic position and the same anatomic stress, they should produce the same finding, right? So an examinee that reports lower back and radiating left leg pain on straight leg raise would be expected to report the same pain with a sitting straight leg raise maneuver. Or they should demonstrate some other type of physical sign. For example, the examinee would be expected to be unable to straighten the knee on the sitting leg raise. They would be unable to straighten the knee, especially in the presence of a true radiculopathy. As that sciatic nerve tension starts to build, they would prevent the straightening or full extension of the knee. Or the examinee would be expected to lean back quickly, thereby reducing the angle of hip flexion as the knee comes out into full extension. In any event, there should be consistency between the overt test and the distracted test, and any inconsistencies would cause the examiner to be alert for symptom magnification and or malingering. Waddell also described regional findings and overreactions as categories of testing. With regional findings or regional disturbances, these are findings, they're generally neurologic findings or reported neurologic findings that deviate from known normal neuroanatomy. So an example would be an examinee that reports complaints of entire leg weakness. Now, entire leg weakness would involve multiple nerve roots and multiple peripheral nerves, and that would be unlikely in the absence of some special circumstance, correct? Another example would be an examinee that reports pain in the entire front of the leg with no pain in the back of the leg. Another example would be a report of entire foot numbness, also known as stocking anesthesia, or entire hand numbness, known as glove anesthesia. Now, as the hand and foot are served by multiple spinal nerve roots and multiple peripheral nerves, a finding of stocking or glove anesthesia would be a concern, and it certainly should be supported by other physical examination findings. Overreactions. Overreactions are subjective findings of the examinee's reaction to various test maneuvers, and signs of overreaction could include verbal reports, facial expressions, and other bodily reactions that are out of proportion to the stress of the test or the maneuver. And we've gone over several of the different types of pain behaviors, and the pain behaviors could also be examples of overreactions. Overreactions need to be taken slightly with a grain of salt because reactions to pain are highly personal and of course are influenced by a variety of factors, including cultural background. Nonetheless, reactions to pain should be somewhat proportional to the stress and somewhat proportional to the demand placed on the anatomic structure, and reports of pain or impairment that are grossly out of proportion to that expected could be a sign of symptom magnification. Now, just as there are no specific tests that can be used to quantify an examinee's level of pain, there is no one test that can definitively identify symptom magnification or malingering, and Waddell's maneuvers are no exception. A positive finding on any single Waddell category does not automatically identify your examinee as a malingerer. What's important is that the Waddell signs indicate a pattern of behavior that may be consistent with malingering, it may be consistent with symptom magnification, and any pattern established with these Waddell maneuvers must be checked, and it must be examined for its own consistency with the medical history and other observations of the examinee. Again, no one maneuver indicates anything. It's the pattern that we're looking for. And a pattern of symptom magnification may be supported with positive findings on some additional physical examination maneuvers, and I give you examples of those here. And there are distraction maneuvers, and there are simulation maneuvers, and we'll go into insincerity of effort maneuvers as well. And I'd like to give you some examples of each. With distraction maneuvers, examples that are described in the literature include situations where an examinee claims to have inability to move the neck on direct testing maneuvers, however, is observed to rotate and bend the neck in the completion of paperwork. For example, you might note that their head is in a prolonged forward bent position in the completion of paperwork, or even in following the examiner's movements around the room. So you would examine that for consistency. An examinee could claim to have the inability to bend at the spine on direct testing, however, is observed to neatly remove their shoes and socks for testing the lower extremities, and that's just an example. Another example of a distraction maneuver would be an examinee who claims to have the inability to bend at the waist on direct testing due to report of lower back pain, however, is observed to sit comfortably with the hip flexed to 90 degrees. Doesn't that involve bending at the waist? Another example would be an examinee who reports lower back and radiating right leg pain with straight leg raise testing, however, is observed to bend over and touch the shins, the feet, or the toes without a reflexive bend to the knee to relieve the supposed sciatic nerve tension. Let me repeat that. This is something that you'll come across frequently. An examinee reports lower back and radiating right leg pain with a straight leg raise maneuver. However, is observed to bend over and touch the shins, possibly touch the feet, possibly even touch the toes, without a reflexive bend to the knee. This is known as a negative Neary's bowstring sign. In a case of true radiculopathy, true sciatic nerve tension, there would be a reflexive bend to the knee, which would be the purpose of which would be to relieve the sciatic nerve tension, and that would be known as a positive Neary's bowstring sign. Various simulation maneuvers include the log roll maneuver, and the log roll maneuver, to perform the log roll maneuver, you would do this in the case of an examinee who claims to have lower back pain with all movements of the lumbar spine on direct testing, and who also complains of lower back pain when the leg is internally and externally rotated at the hip. Now, this is typically done with the examinee in the supine lying position. The examiner places one hand on the examinee's thigh and the other hand on the examinee's calf or shin. Rolling the whole leg at once, the examiner first internally rotates and then externally rotates the entire leg. This is the log roll maneuver. Now this maneuver causes movement in the hip socket joint only and does not involve the lumbar spine. Therefore, a report of lower back pain or body language to that effect would be a non-physiologic finding. The hip wiggle maneuver is done also with the examinee in the supine position. In this case, the examiner flexes the hip and the knee both to 90 degrees. And it's important to simultaneously flex at both joints to prevent the development of sciatic nerve tension. At the 90-90 position, the examiner then internally and externally rotates the hip joint. This may produce pain in the presence of a hip joint pathology, but should not be a source of lower back pain. A report of lower back pain or body language to that effect would be a non-physiologic finding. The toe ankle dorsiflexion plantar flexion test, also known as the Gordon-Wellberry maneuver, is also done in the supine position, and this is done after performing the sciatic nerve tension signs such as the straight leg raise maneuver and Bragard's maneuver. At the completion of Bragard's maneuver is generally how I do it. The examiner flexes the supine examinee's hip and knee and places the examinee's foot on the examining table. So can you picture this, doctors? You flex the hip, you flex the knee, and place the foot on the table. So the knee is up off the table. With one hand on the examinee's elevated knee and the other hand beneath the examinee's foot and toes, the examiner strongly dorsiflexes the toes and ankle of the foot, similar to the dorsiflexion of the Bragard's maneuver. Right? It's exactly the same way that you would handle the ankle as you did with the Bragard's maneuver, only now there's a bend in the knee and there's a bend at the hip, and it's no longer a straight leg maneuver. Now, this should not produce sciatic nerve tension because of the flex positions of both the hip and the knee, but because this maneuver follows closely behind the other sciatic nerve tension maneuvers such as the straight leg raising maneuver and Bragard's maneuver, the injured worker does not know this, and they expect sciatic nerve tension. So a report of lower back or radiating leg pain would be a non-physiologic finding. Insincerity of effort could be an inconsistency that is a glaring inconsistency on physical exam, and these are examples where the examinee understates their capacity or their ability to perform certain maneuvers. And like I said, one of the main methods that examinees employ to overstate their disability or impairment is by exaggerating the loss of physical ability or physical capacity. And this may be detected on symptoms and activities of daily living questionnaires and also in the physical exam. And examples of insincere effort or inconsistency of effort on physical examination maneuvers could include the presence of a positive or a negative minor sign. And let me describe this. Imagine an examinee who demonstrates weakness on resisted knee extension testing. This is, for example, L4 nerve root testing or femoral nerve testing. Resisted knee extension, that would be part of the lumbar spine neurologic exam for the L4 nerve root. So the examinee demonstrates weakness on resisted knee extension and yet is observed to be able to rise from a sitting to a standing position without the use of his hands. We would call this a negative minor sign. Negative minor sign. A negative minor sign in the presence of reported weakness on resisted knee extension would indicate an insincere effort on resisted knee extension. Another example would be an examinee who demonstrates great difficulty in rising from sitting to standing. This is known as a positive minor sign, and yet is observed to be able to perform the repetitive squat maneuver. Okay? Rising from a chair and doing a squat involve the same mechanics and the same motion. And if there's great difficulty in rising from a chair, there should be great difficulty in performing the repetitive squat maneuver. Otherwise, you would note an examination inconsistency. Another example would be an examinee who demonstrates weakness on resisted ankle dorsiflexion. This would be an example of testing the L5 nerve root. Or an examinee who demonstrates weakness on resisted ankle plantar flexion. This would be in testing the S1 nerve root, and yet is observed to be able to heel walk and toe walk without difficulty. A maneuver that requires strong ankle dorsiflexion and strong ankle plantar flexion. Another example would include a supine examinee who reports inability to raise his supported left leg out of the examiner's hand. This is known as Milgram's maneuver. Milgram's maneuver, the ability to raise the leg out of the examiner's hand. So in this case, the examinee is reporting the inability to raise the leg out of the examiner's hand, and the inability is due to a report of lower back pain and or leg weakness. Now, a sincere attempt at this maneuver involves stabilizing downward counter pressure applied by the opposite leg to the examiner's other hand, and this can be felt by the examiner. Now, picture this in your mind, doctors. You've performed this maneuver, and let me refresh your memory on it. You are standing at the examinee's feet of the supine examinee, and you are facing their head. You have both of their legs off the table to approximately 6 or 12 inches. Their right leg is in your left hand. Their left leg is in your right hand. You ask the examinee to raise the left leg out of your right hand. Examinees believe that this is a maneuver to test the strength of their left leg. It is not. It is a maneuver to test for the counter pressure being applied to your other hand. In this case, this is your left hand. So as the examinee attempts to raise the leg out of your right hand, again, he's raising his left leg out of your right hand, there should be a definite counter pressure into your left hand by the examinee's right leg. This is a stabilizing counter pressure that allows the examinee to stabilize their torso as they unweight their left leg in an attempt to lift it out of your hand. You are evaluating the counter pressure, not the lift. In the presence of a sincere effort, you'll feel a good counter pressure being applied to your, in this case, your left hand. This is known as a negative Hoover sign. A positive Hoover sign would be the absence of stabilizing counter pressure. And in the absence of downward stabilizing counter pressure, there would be a suspicion of insincere effort. And these are just some examples of examination maneuvers that you can employ, and I'm sure you know many examination maneuvers that you use, and this is by no means an exhaustive listing, and you probably have your own examples and experience with inconsistent examination findings. With regards to physical examination maneuvers, even those outlined above are in large part subject to the examinee's conscious control, and therefore can be influenced by factors outside of the reported pain syndrome. Now, the only truly objective physical examination procedures that we have, and I mean the truly objective tests, are the deep tendon reflexes and measurements for atrophy. And in limited circumstances, also gait, which I'll explain. Now, atrophy measurements are objective measurements because atrophy measurements cannot be influenced by examinee factors. And in the presence of true pathology, such as, for example, an L4 nerve root lesion, which causes weakness of the quadricep muscle, or, for example, in chronic leg pain following a total hip replacement, there will be atrophy due to pain, due to disuse, due to favoritism, or due to denervation, and this can be measured with a tape measure. And measurements for atrophy should be obtained at 10 centimeters above and below the olecranon process of the ulna for upper extremity measurements, and a fixed distance, generally 10 to 15 centimeters above and below the tibial tubercle for lower extremity measurements. And while there is some variation in where you do your measurements, in general it should be done at the largest circumferential area of the extremity, and also the distances, whatever distance it is that you do use, should be symmetric from side to side. In addition to reflex testing and measurements for atrophy, and we'll go over deep tendon reflexes in a minute, it's my opinion that gait analysis also represents a true objective physical examination maneuver. And this requires a little explanation because, of course, like everything that we've discussed so far, gait disturbances can be fabricated, and gait disturbances can be exaggerated, and this requires additional investigation to determine the cause of any noted gait disturbance. However, in the presence of a normal gait, let's say, for example, our examinee presents with a normal gait, what can we conclude in the presence of a normal gait? And again, I refer you to a more in-depth discussion of gait in our article, Gait Disturbance and Assistive Device, also available from easyqmece.com. But let's say, for example, you meet your examinee in the examination room, and you greet them, and you meet them,